No, they can. Oh.
Okay, good morning, everybody. Sorry for the delay in getting us started, but thank you all for being here. And thank you for those who are attending virtually. My name is Dr. James Economopoulos. We will be recording this session and we will be putting it on our Tex-CHIP website. We're going to begin with a panel discussion and we will be talking about intellectual developmental disabilities. Tex-CHIP is a program that is funded by HRSA, the Health Resource Service Administration, and it is to strengthen the behavioral health workforce in Texas. And so we do various trainings on special topics. So we're really excited today to be talking with you all. And we're going to begin with our panel discussion. And I'm just trying to see if I can make this document a little bit bigger. There we go. I think I can. Can you all still see the case presentation on Zoom?
Yes.
I just want to confirm that it's still sharing the same screen.
Yes.
Okay, great. All right, thank you. So I can go ahead and have now the panelists introduce themselves, and then we'll go ahead and we'll have our case study presentation.
Edit my.
Wow. Trey, would you like, Trey, I believe you're muted. Would you like to go ahead and introduce yourself?
Yeah, absolutely. My name is Trey Bell. I'm currently in fourth year at Western Michigan University, working on my doctorate in counseling psychology. Currently, I'm involved with dissertation. I have a few years of experience working with individuals that have IDD, along with a myriad of different clientele. That's age ranges all the way from 3 all the way to 65 or whatever. And so I have some experience working with kids with IDD, but specifically my main focus is normally working with children. And so I've seen a lot of cases as I've been in the school systems to identify this, sometimes brought in kind of as an expert to kind of identify the needs of certain children. And so thank y'all for having me. I'm excited to get into this case.
Okay, I'm Susan Lagrone. I am a licensed professional counselor in Corpus Christi. I'm the coordinator for the IDD transition support team for this region. So the team covers more than Nueces County. It starts at B and Live Oak counties, goes down to the valley and over to Laredo. So it's 17 counties in total. We're just a program based in at Nueces Center for Mental Health and Intellectual Disabilities. I've worked mental health and IDD services since the 90s. I'll leave it at that. Okay.
Okay. I'll go ahead and I'll read the case study out loud. And then I'll let Kelsey and Lena facilitate the questions. All right. So Wasim is a 9-year-old boy who is currently in 3rd grade. He was referred to the school psychologist by his teacher due to concerns about his academic performance and behavior in the classroom. Wasim's teacher reports that he struggles with basic reading and math skills and often appears distracted and unfocused during lessons. Additionally, Wasim has difficulty following classroom rules and frequently interrupts his classmates. For his personal history, Wasim was born prematurely because he was birthed only 7 months into his mother's pregnancy. During his infant life, Wasim was abandoned by his mother, even before he was completely weaned from her. This forced his father to look for a babysitter. For a long time, Wasim experienced a lot of this. I think you just have to mute. Okay. Okay.
You have to mute yourself.
This forced his father to look for a babysitter. For a long time, Wasim experienced a lot of difficulties trying to meet the minimum threshold for admission into sequential class grades because he always trailed among the last 5 candidates in any class. This was witnessed from his admission into first grade. His parents reported Wasim hugged strangers in public settings and has difficulty with daily living, hygiene skills, and fine motor skills. When Wasim communicates with others, he uses make-up words that others couldn't understand, so he really does not have any playmates. For his family history, Wasim is the eldest child in a family of 3 children. His younger sibling is a girl, Sophia, aged 9 years old. The youngest child is also a girl, and she is 3 years old. Among his siblings, Wasim is deemed to be the child who has experienced the most difficulty in learning and social functioning. There have been no vivid or confirmed reports of intellectual disability among any of Wasim's family members. His family is a middle-class family, but also hails from a background of child neglect, with many of Wasim's relatives having been abandoned by their parents at an early age. Wasim's parents are no exception. The degree of attention they give Wasim is inadequate because little attention is paid to Wasim's slow intellectual development. In this regard, Wasim is left to live with this condition alone. All right. I'm gonna go get the waters.
Okay. Okay, y'all on Zoom, can y'all still see it? You still see the screen?
The screen's just changed to your picture.
There you go. Not the question. Okay. Make sure it's on the right. There you go. Okay. Can y'all hear me on Zoom?
You're very low.
Very low.
It's because I have the microphone.
Oh, you have the microphone?
I have the microphone.
Okay, so I'm gonna try to speak up. What is your clinical impression of Wasim and what was your first? Okay, how about now? Okay, we good. Okay. What is your clinical impression of Wasim and what would your first steps be in assisting him? Yeah, Troy, you want to take it first?
Sure. And so as I look at this case, I am interested in knowing a little bit more about his background. I don't know his ethnicity. I don't know things related to his family members. So that would be the first assessment that I would do normally with the family. I'm kind of assessing some of those other cultural factors that we're probably missing based on this case, based on what I have information based on this case. And from my standpoint, it seems like there's a lot of isolation that Wasim deals with that hasn't been properly addressed in the school system, nor the family is addressing it. And so I would like to know if more information. I know he has a history of abandonment, but I'd like to know more information related to the abandonment that continues throughout his family, where he's this one that's isolated. And then also, we'll get into it later about the assessment, but that's my first just kind of flashpoints of the clinical persons that I see with the Wasim.
So, as Mr. Bell indicated, trauma can cause developmental delays. So you do have to know a little bit more about that. He could also have something like ADHD, which was causing him problems with attention, right? Or any other number of things. So, but I'd start with assessment. In Texas, they refer to it as a determination of intellectual disability. Just to see if there is anything indicating an intellectual disability before you go down the other paths. But generally, his problems, most likely his problems are going to be a combination of factors: the background, the social supports in his environment, or the lack of social supports in his environment, and he could also have a coexisting mental illness with an intellectual disability. But I'd want to start with assessment to see a little more along the lines of what we're looking at. But you would want to know his ethnic background and whatnot, because sometimes that's going to skew his test result.
Well, speaking of assessment, what assessment might you use in your session to support Wasim?
Generally, you'd start with an intelligence test. They're usually using the Wechsler intelligence skills for children. You'd also want at least one measurement of adaptive behavior, something like the Vineland or the something called an ICAP. Or, I mean, there's others. There's an AIDD one. You'd want to also assess his academic level of functioning. So things like a K-bit or I'm trying to think what K-bit stands for. It's Kaufman something. Or you would do a like a RAT, wide range assessment test, things like that. You'd want to kind of combine all those.
Yeah, I would also agree. I would also add differential ability skills that can also provide some greater context to some of the strengths that Wasim does have, along with definitely a Wechsler inventory scale. The fifth edition would definitely be appropriate. But again, you would have to bring in a lot of different other assessments related to that to kind of get a complete picture of what Wasim has and what he may be lacking and what we could improve to kind of bring him up to speed based off, I believe, the developmental level that he would probably be at based off of some of the interactions that he's having. He'd probably be more closer to 4 to 5-ish instead of 9. And so treating him as such would be more beneficial than trying to see like, hey, this is a 9-year-old we're dealing with. He should be at this level. He may not be at that point. So you have to assess for those different things and having appropriate measures. And then much like the other panelists spoke about, also knowing his ethnicity, knowing his race would also play heavily into that, because we know some of these measures have been normed to white norms. And so we would need to know where he would fall in that if we were to use those assessments.
At this point, would you be recommending any sort of functional assessments? Because they told me you had a behavior analyst background.
Yeah, definitely. We could definitely get him in to see to do some functional assessment, just seeing where he is with his fine motor, gross motor skills. That could be helpful. But again, if we were to treat him as such as if he were in my opinion, 4 to 5-ish age range, that would probably be on par to where he's at currently. I don't know that currently without doing an assessment, but just getting him to do certain things, and he may need some additional assistance from, I don't know, I think about some of the kids and also assessing him. He also could be on the spectrum, possibly, based off of some of his it's highly likely that seeing a different psychologist, they may assess him as being on the spectrum. So ABA definitely would be an appropriate approach to seeing some of those functional things and then also helping him treat those different things. But I think I'm getting way past the treatment part. I'm gonna let y'all continue.
We kind of going into question 3. What treatment approach would you implement with Wasim? You can go. Yeah, you could. You was on that track, so you could go.
Yeah. So as I was saying, ABA can be an appropriate measure. Oftentimes that we see children that do have IDD, they've been diagnosed with IDD, autism, they're on autism spectrum, They also sometimes have these other things that they're being diagnosed with, like ADHD. So oftentimes when I was doing my ABA work, I did ABA work for 3 years. And again, I worked with a bunch of different, I worked with smallest of kids. I worked, my youngest child was 2. And then I worked all the way up to like 22, working in the work. And it's very insightful on how different psychologists would give diagnoses. But oftentimes you would see that they had IDD, they were on the spectrum. And so as we were assessing with this, ABA was helpful for finding where they were lacking at in skills and just improving those skills. And so certain children, we would focus on particularly like sight words. If they were kind of lacking in reading, they may have IDD. If they were lacking in reading, we would do sight words to kind of bring up those skills and get them on par with the rest of the students. And then we've seen a lot of children kind of graduate out of those programs, whether they graduated. It's not that they're not on the spectrum anymore. It's just that at a developmental function that's on par with their peers. And so you can do a lot of different things in the background. We ran food programs with children that had other issues with eating, fine motors. We had speech pathologists for individuals much like Wasim that would use up these made up words. We would practice to focus on, hey, let's focus on the words that we do know, but we know developmentally 4 to 5 year olds will make up words, so it's not uncommon. It's just bringing them up socially to kind of hit some of those things. And so there's a lot of different things you could do with Wasim based on this case. It's just about, I always find that being creative and finding what's best for the child and trying to bring them on par with other children is the most important thing. And then also making sure that he feels really heard and seen, because he hasn't seen us a lot. He does have these, he has these pretty much invisible boundaries where he doesn't know how to connect with other individuals. And so working on those things, I think that would be more beneficial to kind of reduce some of those things we're seeing in the classrooms. Because it doesn't seem like Wasim has a safe place where he can really be himself and feel wanted and feel seen.
Okay, so forgot a couple of assessment categories. One would be, of course, to do an autism screener. And you can also do, there's also some trauma screeners out there for people, designed for people who might or might not have developmental delays. So you throw those in. So the treatment approach would depend on, what the screening results were, kind of. So as with Mr. Bell, I'd want to work with him on his social skills, on attention, because you can help people increase their attention span. In many cases, you'd want to provide some remedial assistance for his academics. Whether or not I'd want to go into trauma treatment, I'd want to know more about that trauma background. And also do a lot of work on self-esteem, because he's behind, good chance he's getting picked on. Okay. So you'd want to do a lot of work on, feeling good about yourself and your abilities, and you'd look for his strengths and try to promote those.
Okay, so moving on to question 4, how would you include other professionals to provide treatment in an integrative approach?
I'm trying to break their equipment over here. All right, so it's always good to include a speech therapist if you can get your hands on one. Also, occupational therapists are really helpful, for the fine motor difficulties. Depending on how his gross motor is, physical therapy might also be a good adjunct. And since I'm a counselor at this point, I'd probably be reaching out to an ABA person. And then like pediatrician and whatnot, you don't want to neglect. He might have a health problem that causes it. If he's in pain, or if he has earaches, he could be having trouble concentrating just based on that, right? So you'd want to include his pediatrician. If it is determined that he has something like ADHD, you might, at that point, also want to involve a child psychiatrist.
I would only add to what has been spoken about. Also testing for his eyesight also as well. That may also play a part into some of the behaviors that we see. And then also if he has a school counselor at this point, which I'm highly likely he has an individualized plan, a 501 or something of that nature, maybe at the school, it should be in place. If it's not, those things we get in place. And then also, if we're going holistic thing, getting all these people to get on one page so we can create this idealized plan for them, so that what's seen can be successful, especially if he's seeing us as the counselor. And so you had to get a release of information from all these different people to kind of coordinate all this treatment. But you know, just the basic stuff as a counselor you go through.
Okay, so what resources might be helpful for him?
We've kind of touched on them. In Texas, depending on your school district, you might have to bring in some outside leverage to get your 504 and your special ed. So if the family is having difficulties, there are such things as the Texas Education Agency. You can like file a complaint with them and they'll come down on the school district. Disability Rights Texas is another one. The professional resources I kind of hit on.
Yeah, that's Mr. LeGrand was saying. I wouldn't add too many other things. Speaking of that, there is in Texas, you do have to force that. By law, school districts are required to provide those services. So as you as the counselor, as you start to suggest these different assessments, you can't get the school to pay for those things by bringing in a school psychologist, also bringing in ABA. You can require schools to provide that for your child when they have that 504 and that 501, whatever they pay a different name on those individualized plans. But you have to inform parents. Oftentimes parents don't know these things. So oftentimes it's just our job as the counselors informing them, hey, these are your rights as parents. These are things you can require the school to do. And if you don't do, tell them, hey, you're going to get a lawyer and move forward, because school districts don't like that. Now, the school districts will try to get over on you and hire people that's unqualified. And so also inform the parent like, hey, you may want to bring an outside resource in and then require the school to do that. And so that's the things I always like to provide for parents, because oftentimes it's kind of neglected and they don't know. And oftentimes we know the information and then we don't kind of tell parents that. And so just make sure that you stay on top of that, making sure Wasim is taken care of across the board, not just in when they see us and sit down in our clinic or sit down and see us in our playrooms. So that way they can be successful moving forward.
A lot of times, if a parent just mentions lawsuit, the school acquiesces. You don't have to go actually get the lawyer. This is according to somebody who used to work with me, who had been a former special ed director. But it just depends on the school district and their resources, because some of the ones in this area, they just don't have a lot of resources, so they try to delay providing the service as long as they can. Another resource is that, I mean, I left them out and it's where I work. The local intellectual and developmental disability authority for where the child lives. If they can get into services, if he's got an intellectual or developmental disability, that provides them a service coordination. So it's another way of advocating for their needs and finding them resources.
All right. So what, excuse me, what suggestions do you have for novice helping professionals to be mindful of clients within intellectual developmental disability? You can go first.
Oh, I can go first. Thank you, Ms. LeGrand. Sure. So when we think about when we're working with Wasim, even though he may have an intellectual disability, he may have other skills that's at his thing. And so I always like to approach it from a strength-based approach, not just always saying like, oh, this is the client that's intellectually disabled, more so they have an intellectual developmental disability, and that we can move forward. And I always believe that children can learn and they're very resilient in learning new skills and growing. And so just seeing this as a holistic, seeing what's seen for an individual that can one day become anything. And so treating them as such, treating them with respect, but also showing them that you care and that they matter to you, I think would be the greatest influence, because I come from a person-centered, client-centered, child-centered focused therapy model. And so those things to me are the most important. And that's where I've seen the greatest thing, where I see a lot of novice professionals that they kind of talk down at them. They've always want to try to teach Wasim something. I mean, that doesn't always go over well for especially somebody that's kind of been marginalized in those different areas related to their experience. And then they're less likely to want to come in. And when you suggest something that you believe would be beneficial, they're less likely to kind of be involved in that process, especially as we're seeing right now, Wasim is being disruptive in class. And so it didn't, for me, it didn't feel that maybe that teacher has kind of built that connection with Wasim. And so that would be kind of you kind of modeling that for Wasim. And then also, again, kind of that holistic you may have to get with the teacher and then kind of coach them through it. Hey, this is how we want to talk to them. This is how you kind of reinforce some of the more positive behaviors instead of all of the negative behaviors. Because Wasim is he'll start to internalize those things and then they'll add that to a self-worth, much like Ms. LeGrand was speaking about, that self-worth piece and that self-confidence. And so those are things that I would tell novice professionals, just seeing Wasim for the whole being that he is, and not just the disability that he currently has.
Thank you for saying that because you saved me having to do it. Other things is you want to be aware that receptive language and expressive language isn't always developed on the same level. So you may be working with somebody who doesn't have a lot in the way of vocabulary, or they don't use words to communicate very often, but that doesn't mean they can't understand you, okay? Or vice versa. You could have somebody that talks up a storm and sounds like they know what you're saying, but they don't really understand. So always go back and check for understanding. And that's part of my lecture today, so we'll leave it to that. You also want to try to give remember to instill hope for the family and the parents. Because sometimes they get stuck in the mindset too that, oh, well, my kid has this label now, he's not going to accomplish anything. He's not going to be able to do anything.
And so I know this one is kind of hard to answer because we don't really have that background information. But if Wasim was BIPOC identifying, what are some cultural considerations for treatment for him?
You want me to go? Oh, you want me to go? Okay. Yeah, we don't know each other. We haven't met until the Zoom meeting. Okay. Figure out, all right. So just because the person might be, Black, Indigenous, or a person of other color or whatever, it doesn't mean that they're going to have a uniform culture any more than myself as a white woman, it's going to be the same as every other white woman in the room, right? So figure out what the family's individual culture is. Figure out, and you do this by asking them and observing, right? Figure out how their culture views intellectual disability, or autism, or whatever else Joaquin may actually have, right? And once you know how they're, I don't remember the term I want to use. It's like a nuclear, like their family culture, right? So you want to figure out, how that's viewed in their own society, so to speak, right? And try to work within that, because some cultures don't look at it as a bad thing. It's just, oh, it's okay. They're just like that. Some cultures, it's like a pariah, and you're outcast. So you need to talk to them and figure out where they're at and how they perceive what's going on with their son. And that doesn't matter what, race or ethnicity is.
Yeah, I would just as Ms. McGraw eloquently put it, again, get into that family, learning about them is the greatest thing they can give us. The culture consideration. Again, there's not a lot of culture that I know about while seeing in this case. So finding more information about that is very important. And I'm still confused. Does Wasim, is mother in the picture or not in the picture? Because not in the picture.
She abandoned him.
Okay, but it said parent. It said parent. Okay. Maybe I just read it wrong. It said at the end it's parent, but okay, maybe it's just a dad.
Oh, the dad's there.
Okay.
Yeah, so he's got a dad and a babysitter and some siblings.
But it'd be interesting knowing just not just that nuclear family, who else has influences on Wasim's life. So it may be, if he is a person of color, it could potentially be a grandmother or aunt or somebody else that we don't know about that may have more information, that may have talked to his strengths that we don't know about. And oftentimes may not be brought in. So a lot of times when we talk about the school system, they'll only bring in the parents. They won't bring in anybody else. They won't bring in other family that may play vital roles into his life. And so you may have to kind of coordinate that with parents and be like, hey, no, I want to bring in this other family member that knows about Wasim and spends a lot of time with them. And then oftentimes this babysitter, I don't know how this babysitter operates, but also getting them to be a part of this, seeing that they kind of care for Wasim a lot, could provide just not just having parents. I think a lot of times in Western society, we only see the parents as being able to kind of speak to the child's thing. But also what do brother and sister say about him? How does he interact with them? I think all those things would be great information to know, and to provide some context of what culture he kind of operates from.
Yeah. The main thing is to educate yourself and, practice cultural humility, right? Just because the system says this and this and this is okay, it doesn't mean that that's going to work for that particular family.
All right, okay. And last question, in your own profession, what personal example can you share regarding clients with symptoms of intellectual developmental disability?
This doesn't have to do with it.
Just your person.
David, I'll give you a story from a long time ago when I worked at a psych hospital. I did intakes for a psych hospital. Okay, so a mother brought her child in. Child was, I think, in 3rd grade, and she was convinced her child was psychotic. So she's bringing her to the psychiatric hospital. This was in another state, and they kind of operated differently over there. I asked her why she thought her child was psychotic. She said that the child keeps breaking all the eggs in the house. So she must be, and I'm going to use the non-politically correct term, crazy, okay? And I'm like, what else does she do? Well, she's making bad grades, and she doesn't listen. And she had a whole litany of complaints about her kid, but she also had a stack of paperwork. And I said, is that about your child? She said, yeah, the school gave me this, but I don't know what it is. So the school had done testing on her child, but didn't explain it in a way that the mom could understand. So I start flipping through the paper. The child had an intellectual disability. Mom didn't know what that was because the school hadn't bothered to explain it to her in words that made sense to the mom. So I just explained and so I asked the kid at that point, I said, why are you breaking the eggs? She says, I'm looking for the chickens. Okay, that's logic, right? That's logic. She wasn't doing it because she had voices telling her to break them or anything. She just knew that chickens came from eggs and she wanted to find the baby chicks. Okay, so I ended up having to explain what all the paper from the school meant to the mom, and then referred her to the appropriate state agency for assistance. So IDD gets misinterpreted as many different things, right? Just like neglect or trauma responses and things get misinterpreted as IDD. So that's kind of why I started out with, well, maybe some testing would be a good first step.
I'll speak to my own professional. I worked during my master's. I worked in it's a preschool, so it had a 3 to 4 year old. That's why I did a lot of the work. I like working with children, younger children. And so I had the same similar situation, but I found out that the parent also dealt with IDD issues that we didn't know about. And so they believe that this child was just disruptive. They thought he had opposition defiant disorder or something like that. They were just kind of coming up with stuff. And so I hung out with the kid. I would go to the classroom. And they were pretty smart and telling they had some opportunity, but they didn't oppose me. So when I would ask them, hey, you mind let's go play real quick. So I would take them to the playroom. We would have fun. And I was asking questions. And so as I kind of delved through that, learned about their culture, I ended up eventually calling mom and asking her about kind of her history. And then she also said she struggled in class as well. And so it wasn't that the child was opposition, it's just that they had issues related to learning that nobody had properly addressed. And so from my standpoint, that's when I then went to, I had superiors, and I was like, I think this kids need to be tested by IDD. They need to be tested for intellectual disability, not opposition defiant disorder, because it's not what they have. They don't define me. Now, maybe because I was the only male really that was in that community. Also, I was Black, so they were African American. So I guess that kind of helped out with it as well. But as talking to mom and getting this information, I learned they did have IDD, and then they were able to give them individualized plan. And then I was able to kind of relieve some of those issues that they had related to learning. But had I not done that background work and kind of finding out the cultural context of that, that kid would have went through life with this opposition to defiant disorder, not got the proper services that they needed. And then that would have been a disservice for that kid. Because oftentimes we know that if you have opposition to defiant disorder, as you get older, they'll define it as, I believe.
Conduct disorder.
Yes. Yep.
Okay.
It's been a minute since I've been doing all this diagnosing.
Well,
But
I'm a mental health person, so
yeah. And so they'll do that later in life and you'll be stuck with that label. And so we have to be mindful, very mindful when we're doing assessment, when we give out diagnoses, that these diagnoses will have ramifications later. And so we have to be kind of thorough in the way that we approach it. And that was always been my intentionality, is not giving the kids something that I know will effective later down the line if it's something else. And a lot of psychologists will just do, I know checks they'll do as I'm working to be a psychologist, they'll do an assessment like the WISC and be like, the WISC, the Wesley inventory scale, they'll just do that quick and like, yeah, they got intellectual disability, and it may not be that. And they don't actually spend time knowing to get to know the kid, getting to know the parents, getting to know the culture. And so oftentimes it'll be y'all, the counselor. Well, I'm a counselor by heart. It'll be the counselor that's really spending a lot of time with families, spending time with kids that have a better sense of what this is. And you may have to advocate for your client to have a different diagnosis based off of this. And then telling parents, hey, go get a second opinion. I don't believe it's that, I believe it's this. And so just being intentional of that, that's what it reminded me of that case particularly, because they'll say anything. I don't know why psychologists go through and say anything. It kind of irritates me, even though I'm working to be a psychologist. But
or psychiatrists will just declare that the person has an intellectual disability with no testing. You get that sometimes too, because they're going off observation. But the thing also to remember is that anybody can make a low score on an IQ test if they're having a bad day. Because if they're not attending, their score is going to be bad. Could also be that they have a learning disability and not an intellectual disability. So don't take them as gospel. If you can like get more than one like over time, that's a better indication if the person's really got an issue or not.
Any last thoughts or ideas you want to share about Wasim or just in general?
any particular thing y'all looking for?
Yeah, turn it to the students. Do y'all have questions? Oh, we have one question. Oh, two. Okay. The question was, how would you address Wasim's parents if you would involve them? Well, the one that was there.
You have to involve them, but it's like, I mean, he's a minor. You got to get their consent to do anything. I mean, you've got to involve them. Explain what you're doing. Explain why. See if that's what they want. I mean, it's informed consent. You'd start with that.
Yeah, I would just ask as well, approaching the parents, because people may have this reluctancy to approach parents. Most parents want what's best for their children. And a lot of times they aren't informed or educated, and a lot of times providers will just tell them things without asking them their input. And so that's the way I would kind of collaborate with the parent, like, hey, what are things that you want to, what are the things you want to happen with Wasim? Again, he 9, so he can't give consent without parent there anyways. And so even in therapy, I always try to make a contract with parents. It's informal, but it's just, hey, what are the things that you want me to have to tell you if it were to happen? And so oftentimes we know the ones like if they're harming themselves, harming others, And then parents will say other things. So I just always like to like, what is it, like drugs? And then they'll be like, yeah, drugs, sex. And I'll let the kid know, like, hey, you tell me about this, I gotta tell your parent. Just to keep that confidential trust, but also always giving parents kind of updates on how the kid is doing, how they're progressing, what other things am I doing? Like we mentioned 1,000 different things you can do. Mention that to the parent, like here's some other things that we're doing. And then sometimes I'll ask parents, like, hey, we're doing this in therapy. Would you mind just like, looking out forward to seeing how it's kind of generalizing at home, just so we can get a complete picture of like, is this generalizable across different sectors? Or if is it just something that he's doing in here? How do we kind of replicate that so he can be successful outside of just the counseling area of space that we have right now? And so that's how I would kind of collaborate with dad. And then again, if there's a babysitter there, any family member, what other feedback do they have, and how can we generalize these other behaviors towards him?
And you'd also want to, if you're teaching something like social skills or using behavioral interventions of any kind, you want to get the parents to also do it with them or the parent and the babysitter to do it with them at the house. So rehearsing, practicing, helps him learn.
Did you hear him? No? Okay, so he asked like basically, how would you communicate or assess for the trauma if he has a deficit in communication?
So, all right, in terms of standardized stuff, I don't have that. I don't have a list of them with me, okay? But there's like standardized, paper measures that like caregivers can rate and stuff like that. Ask them what happened to him. Ask the caregivers what happened to him. If his speech is really limited, you would want to go into like, okay, so did you notice any changes after his mom left? Did he seem to lose some skills? Did he cry? Was he inconsolable or whatever, right? Does he report having nightmares? So you can ask about trauma symptoms of the caregivers is one way of figuring out how something might have affected him. You can also, direct observation. And depending on, where he's at, you can ask him. You just want to be careful in how you phrase things.
Yeah, to add to Mr. LeGrand's point, the only thing I would add is I did a lot of play therapy. So a lot of times those things would kind of come up in therapy. And then all I would do is kind of like she mentioned, just kind of collaborate that with parents and say, hey, I noticed like your kid is doing some of these plays. I just want to kind of understand what kind of went on. And the parents then may be more likely to open up than just me coming straight out and forward saying like, oh, I know your kid got trauma, tell me all about your trauma. And then they may be still dealing with their own trauma as well, related to not only mom abandoning Wasim, but also abandoning them as well. And so those are different things you kind of got to be mindful as we talk about trauma, because trauma is very complex and it doesn't just always affect the one child we're working with. It may affect the whole system as a whole. And so those are the things that I kind of try to be mindful in. When I'm just, it's more of a touchy subject, especially when we're dealing with a child. And then there's other things that we may have to kill in time because there may be other trauma we don't know about that may come up, and then that may force us to do a report. So I'm always intentional on how I get that information, how I kind of relate it back to parents, but also always communicating and being open about what's my thoughts related to the case, what's my thoughts related to the client, so that the parent is well informed, that they don't feel like it's an attack. If something were to happen, like say Wasim says, hey, I've been getting hit by my dad, like in the face, or some level of abuse, now I have to like report that. Those are things that you kind of got to be mindful in. So even in those, I'll still have a conversation with the parent before I were to do it, but let them know like, hey, I have to do these things.
And you might not just want to ask him, have you had trauma? Because trauma is an individual kind of thing, right? So you're asking about things like, has he reported that the other kids at school pick on him a lot? You can ask, there might have been medical trauma, right? So you can ask, has he had to have any surgeries, or did he have any serious illnesses, or has he had to be in the hospital? So you can ask about things where it would be likely that a person would experience trauma without using the word trauma. So, like, why did the family have to move from where they used to live? Was there war, right? We don't know. So you can ask about stuff like that instead of just saying, you know, does he have a history of trauma? Okay, no, you said no, check no and go on. Yeah.
Any other questions? So, I don't. But yeah, so she came into the emergency room and her parents, pretty much just said that they didn't want her anymore because they had adopted her. And she was nonverbal, and had a lot of violent outbursts. So her parents just said that they didn't want her anymore and they left her at the ER. As a counselor, how would you work with a social worker and how involved would you be in like certain areas, or what areas would you leave to the social worker? What would it look like to work with a social worker in that situation? Does that make sense?
What was the first part of the question?
So she was working, a child was abandoned in an emergency room for, she was violent and nonverbal, and her adoptive parents basically said they didn't want her anymore and left her there. And they found that she had an IDD. What I'd mentioned when they were bringing the mic back over, she wanted to know, like, how much of it would be counselor working with and how much would be social worker working with. And what I mentioned was that would be CPS working with. And so once CPS takes over, your role and how much interaction you can have, it's kind of defined by CPS. Unfortunately, I mean, that's just how it works. They take custody, so. Assuming they involved you, you and the social worker figure out who's doing what, would be the easiest thing.
Yeah, and nothing else that CPS, once they get in part, is unfortunately you kind of don't have any much power, because now they're technically the sole guardian of that individual. So you no longer have any say so. You would hope that they would continue to, but sometimes they may place them somewhere else. And if they're that violent, they may put them into like a group home or something like that. Then you wouldn't have any contact really with them. So yeah, unfortunately, when those cases were to happen, just gotta chalk it up to the game and counseling for the most part.
Another question? Okay.
Well, that concludes our panel. Thank you so much, Mr. Bell, for being here, for your insight, and Ms. LeGrone. Turn it over. Okay. Okay, so to our people online, we're about to take a 15-minute break, and then we'll come back and get the training started. Thank you so much again.
Do I need to stay? Well, I'm good to go.
I know you good to go. Thank you.
Welcome.
Not in front of the slides, like I like to be. Tell me if it's where you can hear, or if you're just hearing breathing and a heartbeat, and I'll move it. I'm not really a microphone person. you need to share the screen. Oh, this Zoom. Here.
Do you want to keep it? Oh, you can keep it like that.
Yeah, I mean, that's the screen they want to see.
There we
We're still morning, okay. So good morning again. As I mentioned earlier, I'm Susan Legrone. I am the Transition Support Team Coordinator at NUS's Center for Mental Health and Intellectual Disabilities. For the ones in the room, I've got brochures if you want to know more about what it is. But I'm just going to I'm going to explain it for the people on Zoom. Transition support teams are funded with federal money follows the person grant funds. Okay, the grant numbers, oops, it would help if I advance the slide. Sorry, guys. It's not doing it. There we go. I'm used to a clicker. Okay, I'm just spoiled. All right, so there's a grant number on this slide. The funds allow us to provide educational opportunities, technical assistance, which is usually answering questions about how to do something or finding resources for a person, but technical assistance can be lots of things, and case consultation activities to local intellectual and developmental disability authorities, local mental health authorities, home and community-based services providers, Texas home living service providers, class service providers, deaf-blind multiple disability service providers, and pretty much anybody who might be helping somebody with IDD. The idea is to reduce the person with IDD's risk of being admitted or readmitted to an institution. Also, we help with transitioning from institutions back out into the community. There are 8 teams across the state. So that kind of gives you an idea because Texas is really big, right? So each team has its own region. We're lucky because our entire region, the farthest is a 3-hour drive away. So we're really lucky. The one based in Dallas goes all the way down the Texas-Louisiana border, for example. So the resource is there, but in some parts of the state, it's spread thinner than it is here. So what we're going to talk about today is prevalence of co-occurring mental illness and IDD. We're going to try to give you a better idea of cognitive and emotional capacities of people with IDD and talk about some traditional psychotherapies that can be used with people with IDD. You just usually have to make a few adaptations. Because what happens is a lot of times people see IDD on that diagnosis sheet and they just make the assumption that the person doesn't have the capacity to benefit from therapy, and that's incorrect. So there are some barriers. There's a problem with people being willing to treat persons who have IDD. There's outdated information floating around. Back in the day, they didn't think a person with an intellectual disability could also have a mental illness. Anybody have an idea why that might have been? And I can't see the chat. Is there a way I can no, if I put the chat up in there, everybody's gonna see the chat.
Yeah, there's a way.
I don't. All right, is there a way that's gonna mess everything up? I use Teams at work. I don't use Zoom? So-
You can just click here and then you can
Okay.
see if anybody has any questions and
Okay.
it'll notify you if somebody
All right,
does.
so if I see a little red, whatever. then-
Yeah, I'm
okay.
just making sure we're recording too. Yeah, we're good.
Yeah, that was your people. I didn't touch the recording. So anyway. Yeah, they didn't used to think, so there was this notion that if a person had an intellectual disability, they didn't have the emotional capacity to have a mental illness. Okay, so that's, like I said, that's archaic. But there was still some of it going around back when I worked at the State Supported Living Center, which was a long time ago at this point, but even that was the 90s. You'd think they would have figured it out by then, right? As professionals, you know, the need for psychotherapy is high in general, right? Think there's enough counselors in Corpus Christi to meet the needs of all the people who might actually benefit from counseling? Insurance aside, let's not even worry about whether or not they could afford it, right? There's waiting lists for everything, right? And as professionals, generally, they don't talk about IDD when they're doing the training, all right? You guys, I mean, it's unusual that we got called in to talk to counselors in training. So, you know, there's like some IDD specific skills that come in handy if you want to provide services to somebody with IDD. It doesn't mean you can't, it just means you have to change your mindset a little bit. And there's not a lot of training about that. We talked, there's a doctor, I'm trying to remember what state he's from, but he's developed a training for medical professionals on common illnesses in people with IDD and how it might look like if the person isn't really verbal. Because he said when he went to med school, they didn't mention it. He learned on the job working at some institution in the state he's from. And, you know, it was trial and error figuring out, okay, what this meant, what that meant. Then he figured out there were some similarities amongst it and, you know, wrote a book and made a training. So they don't really talk about IDD as a thing in and of itself and some adaptations that can be made if you want to treat people who have it. So there's some differences in the mental health and the IDD system. How many of y'all have any experience with the mental health system, like at the local mental health authority level or anything like that? Working there, done a walkthrough, anything? You did? Okay. So how does that system work? All right, you don't say badly, we know. It's a safety net, okay? It's a safety net. But like, all right, if you were on the mental health side, okay. So what did you do? Okay, so you're your youth case manager. And did you have a doctor there? Yeah. And did you have counselors at youth? Yeah. But I mean, there was somebody there, right? Yeah. And as a case manager, depending on your caseload, you would do something called skills training, right? Which is like psychotherapy light. You're teaching, you're teaching skills, right? So the mental health side provides treatment, okay? The IDD side, not so much, all right? The IDD side, at least in our county, and since I just went to a statewide conferences in a lot of counties, doesn't have a psychiatrist handy unless the mental health lets them use theirs. They don't have counselors working for the IDD side as a rule. They have people called service coordinators that their thing is to link people to other services outside the center or sometimes inside the center. There is a split. There's something called provider services at MHID, and they actually provide habilitative care and treatment and places for people to live. But the local authority part doesn't do any of that, unlike the mental health side, right? So in IDD, since they don't figure you're going to recover from IDD, it's more about providing supports. And a lot of times, depending on the provider agency, there's not a lot of, they don't think, oh, they're going to gain so many skills, right? It's just, that kind of depends on who you get. Okay. The treatment's outsourced to these companies around town that provide things like group homes or host homes or day programs and things like that. But when the outside, like law enforcement looks at it, they expect the IDD system to operate just like the mental health system. And so it causes some confusion because the mental health system's providing treatment on site. The IDD system, the local authority part, is providing oversight of the treatment that's happening off-site. Is that clear as mud? Because if it is, that's about how everybody who works in the system looks at it too. Okay, some of it just doesn't seem to make sense. So intellectual disability systems are looking at trying to meet the individual where they're at, and they're looking on habilitation. So like, okay, Susan doesn't know how to manage her money, so we'll do money management training, but we're also going to make sure she has a rep PE, you know? Or Susan can't do laundry, so we're going to, you know, try to teach Susan how to do laundry, kind of thing. It's not so much that they're expecting a lot, that they're looking for workarounds, right? Or Susan's never going to get how to do laundry, so we got to figure out how to get an aid in place to help her with her laundry, right? So, you know, there's this basic philosophical difference. But what people don't think about in the system, the way they set it up, in the state, they said yesterday at this conference that they're trying, so they ran a pilot program where they provided mental and behavioral health care for people with IDD, specialized for people with IDD through the IDD system. But they only did this pilot in 5 local authorities across the state, which left like 30 some odd with nothing, right? So they're trying to expand the funding to expand the program. So they're working on this, the problems illustrated in this slide, but if they get funded, it's still going to be a long time before it happens. So about 1 out of 3 people with a developmental disability also has a mental illness. Okay. Some of that has to do with whatever brain difference or brain injury caused the intellectual disability, also impacted parts that do mood and thinking and stuff. Some of it has to do with the fact that the incidence of trauma amongst people with IDD is very high. Some of it could just be that, you know, their mom had mental illness, their dad had mental illness, they just kind of got it like the rest of the family, and they also had something else on top. But people with IDD experience the full range of mental illnesses, and the incidence of getting diagnosed with a mental illness in the IDD population is a lot higher than it is in the general population. Okay. And again, some of it might be misdiagnosis, because, you know, the kid might be diagnosed with ADHD instead of like recognizing that they've got something else going on instead. Bless you. But a lot of it is just because they co-occur. So like prevalence of mood disorders in general population might be what? Depending on which definition you're looking at, 5 to 20% of people might have depression, for example. So you could just double it for people with IDD, right? And if you add the behavioral disturbance stuff, it goes up to up to 80%. So for a long time, mental health professionals believed that people with intellectual disabilities couldn't experience mental illness. Or if they agreed that they could experience mental illness, they didn't think they could benefit from treatment because of their verbal skills, and they didn't think that a person with IDD could have insight. So everything was a behavior, and you address it with behavior modification, which is kind of morphed into applied behavior analysis treatment, okay? But back in the day, it was behavior modification. In '83, a psychologist named Steve Rice coined the term diagnostic overshadowing to describe the tendency to assess individuals with intellectual disabilities as, or less accurately. So what he was saying was that the IDD was so obvious that everybody would attribute all their symptoms to the IDD rather than thinking that they might have something else going along with the IDD, right? They couldn't see the person's signs of emotional distress. So it's a bias, okay? So if you see the term diagnostic overshadowing, and it happens in other fields as well, but it's kind of bad in ours. It's just referring to a diagnostic bias, okay? Like, I'm trying to give you another example. So like if a person with schizophrenia keeps claiming they're pregnant and everybody just assumes that they're having a delusion that they're pregnant and they don't do anything about it and the person really turns out to be pregnant, right? I mean, it's the same kind of idea, right? You're attributing it to the most obvious presenting problem instead of looking for other causes. However, individuals with IDD do experience the full range of mental illnesses and the incidence is much higher. There's about a 3 to 6 time increased rate of psychiatric and behavioral problems with people with IDD as opposed to general population. And the reason for these so like I'm saying, you know, double and then like one's saying 80% and whatnot. The reason for the variance in the prevalence rates is because people have trouble discerning and defining psychiatric disorders in people who have IDD, right? So it just kind of depends on how the study defined it. And that's how you get the variance in prevalence rate. So these are some things that contribute to these higher rates of psychiatric disorders. Would you say, looking on the slide, that these are the same kind of things that might contribute to somebody without IDD developing, let's just say, a mood disorder, since mood disorders and mood and anxiety disorders? For those of you on Zoom, they're nodding their heads. They're nodding their heads, yes. So, yeah, they have lower levels of social support, right? They tend to get stigmatized, right? Like in the case study, we didn't know if he was being bullied at school or not, but that might make you act out, right? Their social skills aren't always as developed as you would expect for a person of their chronological age. Let's see. Sense of, oh yeah, learned helplessness. Did you guys study learned helplessness yet? Settling in? Okay. So yeah, you should. I mean, it's like Psych 101, right? So, yeah. If you have somebody sitting there telling you, you can't do this because you have blank, right? You can't do this because you're slow. You can't do this because whatever. Or here, let me do this for you because the person with IDD is taking too long to do it and the caregiver's getting impatient, right? So all these things contribute to that sense of learned helplessness. Low socioeconomic level. Couple of reasons for that one. All right, unless they were fortunate enough to be born into an affluent family, right? They're not likely to be able to get a high-paying job. And also, if they want to keep their Medicaid, they can't get a high-paying job because Medicaid in part is based on your income. So the system kind of forces people to stay in a lower socioeconomic class, which comes with its own stressors, right? How am I going to pay my bills? You know, how am I going to get from point A to point B? Things like that. And again, there's a lot of co-occurring physical disabilities, and a lot of times having a child with a disability in a family, in fact, I would say most of the time having a child with a disability in the family would result in increased familial stress, right? Because there's a lot of extra things you have to do. It's hard enough raising a kid. If you raise a kid who has to go to a bunch of specialists and you have to like go advocate for them all the time at the school district and stuff like that, it increases levels of stress. And then you've got the physical stuff, right? The fact that they're more likely to have brain issues, right? Because the brain issues are what causes the IDD, so makes it harder to learn. It's harder to read, right? Language is harder. You can't communicate what you want, so you've got higher levels of frustration. People don't take the time to teach people with IDD coping skills a lot of times. Do anybody ever like have, or like recall have somebody sitting down and teaching you social skills intentionally, or teaching you how to cope with stress on purpose, like intentionally? Like, here, we're going to coping skills class now? No, generally, we pick it up socially, right? I mean, your parent or other caregiver might have taken you aside, you know, it's like, okay, when they call you names, try doing this. You know, they might have, you know, done some, as stuff happened, coaching there, but it's not like it's being intentionally taught to most people. We just kind of pick it up unless we're having a problem with it, and then, you know, we have somebody teach us skills or go to a counselor or whatever. But if you're a person who has trouble reading social cues because of your disability, you may not pick it up organically, right? So somebody has to make the effort to teach it to you. Some of the chromosomal abnormalities or genetic disorders come with kind of a behavioral, like you can expect this sort of behaviors from somebody with this genetic disorder. It's behavioral phenotypes that go with it. Has to do with the genetic disorder. And then again, they have an increased likelihood of having early trauma and abuse. So it's hard to differentiate between, or sometimes, between a psychiatric disorder and the person's behavioral repertoire, right? Because we may have a person who's communicating with their behavior because they don't have the words to do it. So, you know, is the person just trying to tell me something, or is the person responding to hallucination, right? If a person might be experiencing, and I'll do this in a case study in a minute, but a person might be showing signs of a mental illness that if they didn't have a diagnosis of IDD, you would say they had a mental illness. But the diagnostic overshadowing, you know, causes the person, the caregiver to think it's just the IDD, right? So if a person is usually not very talkative, they withdraw a bit and stuff like that, and that's just how they are, they have difficulties with communication, maybe they're anxious or something, and they don't really put themselves out there with others, and people just think, oh, well, they're just that way. You know, they have avolition because of their IDD kind of thing. When in fact they might really be sad But if you've never seen them other than like withdrawn and not talking or whatever, you might just think it's them. And come to find out they've been sad all this time, but you never saw a different version of that person, so you didn't know how to tell, right? Because they weren't able to say, I feel sad or whatever. I worked with a person at the State Supported Living Center, and I was there about 5 years or so. So I knew her for a while. And everybody just, when I got there, I mean, she'd lived there forever. When I got there, they said, oh, she's nonverbal for the most part. I'm like, okay. So we just worked with her like she didn't know how to speak. Shortly before I left, they managed to get her a group home placement in the community. She talked up a storm. Nobody knew she knew how. Right? So sometimes you're getting bad information and you're operating under that assumption of bad information. Because it's possible that she wasn't speaking since the time she got there, however, which could have been in childhood in her case, I don't remember. But apparently she knew Spanish quite well. The only thing I'd ever hear her say, is like, leave me alone, or, little like command things, but she never had a conversation with me until she finally got what she wanted, which was to move out of there. Yeah. So sometimes you just don't get good info, and that's why you miss stuff. And she was being treated for mental illness, by the way, so, but apparently not getting her to the point of happy where she felt like talking to people. And then people, like, they present with different symptoms. So a person, all right, any person, would you say that if you're under a lot of stress, your cognitive functioning changes a little bit? My boss was telling a story in one of our presentations earlier this week about getting pulled over by a policeman. And he thought it was because he had been talking on his cell phone, but the policeman didn't actually see that. He was getting pulled over because his front license plate had dropped off, right, off of his car. But he said, I acted like an idiot because I get very stressed out if I'm pulled over by a policeman for whatever reason, right? So if a person already has to put a lot of effort into keeping it together emotionally and cognitively, like more than, I mean, it takes a lot of effort. I mean, we just kind of do it, but it takes a lot of effort to keep your act together day to day, right? If you have a disability, it takes more effort. And so if you put an extra stressors on the person, their overloaded cognitive functioning, sometimes it makes them look like they're psychotic. They may start acting very strangely. They may not be acting, they may be showing behaviors that like, and I know behavior is anything breathing. I'm not using behavior in a negative sense, like you will hear often in mental health and IDD. I'm just saying behavioral stuff. So like a person might start being very, all right, say a person likes things neat and they get upset if you move things, okay? And if they're under stress, that might be heightened, right? And so they may start obsessively cleaning or rearranging or hoarding or whatever as a result of the stress. It doesn't mean that they have necessarily developed a mental illness, although it could, right? It could be that they've got OCD and nobody was paying attention before. A person who's ill, like with an infection, can start hallucinating and stuff. Like, so they're physically ill, but it's causing psychiatric symptoms. And so people, don't know if it's all right. Has the person now developed a mental illness, or do they just have an ear infection or a UTI or something, right? So in this population, it's very important that everything be checked out, physical and emotional. If a person doesn't have a lot of life experiences, or they don't have the words to describe what they're experiencing in their head to you, you may think they have fewer symptoms because they're not talking about them, right? But in reality, they just don't have the vocabulary to explain what's happening. So it looks like they're not experiencing a symptom of mental illness when really they are. Or if they, oops, yeah, I tell you, I'm gonna break stuff today. If they haven't, like if they're always withdrawn, sometimes it might be harder to see that they're even more withdrawn, right? Did I just skip interface between MI and AD? No, there we go. So if the person's abstract thinking is limited, right? Again, you have that trouble. Or if you have, all right, say you already have a maladaptive behavior that didn't have anything to do with mental illness, right? Maybe I'm a student and I get in a lot of fights at school. Because I do, right? People may be picking on me. Maybe I hate going to school. Maybe I'm trying to get somebody to pick me up and take me out of there, or whatever reason. But then they have a psychiatric disturbance onset, right? They may do more of that pre-existing maladaptive behavior, but people are just thinking it's whatever the original cause was, instead of attributing, instead of allowing for the fact that maybe something else is going on too. Okay. So I'm going to show you this. I think it's going to go on screen. Yeah. All right. So Mr. L is a 20-year-old single white male who resides with his older brother and his brother's family. Mr. L and his brother came for follow-up after medical hospitalization. In the hospital, Mr. L had 2 episodes of acute agitation that required emergency use of benzodiazepine and an antipsychotic. The exact precipitants for these episodes were somewhat difficult to ascertain, but the patient's sister-in-law, who saw one of them, indicated that Mr. L seemed to be giving orders to the nursing staff as though he believed he knew what treatments other patients required. Mr. L was transported to the hospital when his family believed he was having a reaction to pain medication following a dental procedure, which they thought caused a dramatic increase in his level of energy and a complaint of feeling very anxious, irritable, and unwilling or unable to focus and follow directions. Mr. O was typically very introverted and quiet. Indeed, the family was initially pleased when he appeared to be more social and talkative and more willing to spend more time with them. They had not noticed the initial decrease in his sleep due to his tendency to spend time in his room alone most nights after dinner. About 1 week before going to the hospital, Mr. L had insisted that he be allowed to play a video game despite having no prior interest or skill at the game. And later his brother discovered him endlessly looking at the graphics of the game, which featured voluptuous women, but not actually playing the game. So he was looking at girls. Mr. L began talking in an animated manner about wishing to get a car and a driver's license. He was interested in becoming an emergency medical technician or a firefighter, and he began to make frequent requests for his allowance. All right. So what do you think's going on with Mr. L? Yeah. All right. So for those on Zoom, might be mania. Right. And it probably was. But his family didn't notice these little changes in his behavior at first because They figured, oh, he has IDD. He's just, he's finally coming out of whatever, right? And the supported structure of his environment, and they're not probably knowing a whole lot about mental illness, contributed them to their not detecting possible symptoms, right? So psychosocial masking. And his inability to like say, hey, by the way, my brain, my thoughts are going really fast, right? Or I want to go spend all this money. Since he wasn't able to tell him that, and because mental illness is usually diagnosed how? How do we usually come up with a label for a mental illness? Yeah, the DSM. And how do you find out? You're interviewing them, right? Yeah. I mean, so you're interviewing, you're going down this checklist in a book, and if he's not able to articulate, right? Or if maybe he doesn't understand the interview questions, he's going to say no to stuff. And they're going, oh, okay, he doesn't have this, right? So, also, like a person who's got chronically poor sleep habits might not initially draw notice for insomnia caused by mania or depression, right? A person who tends to talk to themselves anyway, especially if they're frustrated or mad, they might not draw immediate attention when they begin to respond to auditory hallucinations because they already talk to themselves. So, in casual, it's like, well, they're just talking to themselves. They always talk to themselves, right? The symptoms, get attributed to the person's ID instead of mental illness. So if you want to assess the capacity of the person for therapy, right? So you need to look at their communication styles and their level of emotional understanding. And you also have to take into account their cognitive functioning. So assessing capacity for therapy doesn't mean deciding if they're going to benefit from psychotherapy or not. It means what kind of therapy might work best and what kind of adaptations I might have to make as a counselor to provide the therapy. Okay. So you've got to adjust your therapy to fit the person's developmental level, their dependence needs, and their cognitive and verbal abilities. So you've got to be willing to be flexible in your approach, and doing these assessments is going to help you make the adjustments you need. Okay. And you might, and I don't know if I have it in here. If I don't, I'll come back to it. I don't remember what's in here. So, but you're looking at developmental age and chronological age, right? Because a person, let's see, say a 30-year-old person with IDD, that's chronological age, right? What's bugging them might be typical of a 30-year-old person. Their way of expressing that distress to you might be at their developmental age, which could be 10 or something, right? So you have to look at them both. But you talk to the person like a 30-year-old. So one thing you need to know is that the person's retrieval, like their ability to retrieve memories and their ability to, like their retrieval and their recognition memory, basically, they might not be on the same level, right? In general, recognition is easier than retrieving. Y'all know this? Would you prefer an essay test or multiple guess? Right? Multiple choice, retrieval, it's recognition memory, right? So people with IDD may have more difficulties with describing past events, and sometimes when they do so, they'll describe it to you, but it's not in order. It's in order to them, but it's not in order to like what third-party witness might say the order of stuff happened. Or they might not have a sense of relationship between events. So if you're assisting people with describing past events, you might want to use something called anchor events to stimulate memory by using recognition. It's not the same thing as that whole recovered memory stuff that was going around a while back. It's just that you're giving them something to tie a memory to help them describe an event to you in a way that makes sense to both of y'all. And I'm going to give you an example in a minute. So to promote the use, to help them use their recognition memory instead of their retrieval memory, you can try things like multiple choice answers on your questions. Don't give a lot of choices, right? Maybe give a couple, and if it's neither one, then go to another couple, right? You can use line drawings, you can use pictures to help stimulate memory. Some people respond better to photographs. It's going to vary depending on the person, what makes sense to them. If you want to have them tell you a story or like create a story, so like if you ask, what happened last week at work when you were upset? That's a hard question. It could be because they were upset a lot last week at work, right? Or it could be that they don't know what you're talking about. So they may, if they answer you, they might recall the events, but they may give it to you like, I know I felt upset, but I don't know what happened, right? They can't connect a precipitating event with their feeling. Some can, lots of people can, by the way. Most people with IDD fall in the mild range, so they're able to do a lot of this stuff. But moderate and lower and low end of mild have more trouble with this. So to use an anchor event might be something like, what happened on payday last week before you threw the box, right? If you have some information from a collateral source. And so if you can kind of start them like by drawing a picture of part of what you were told happened to them at work. And then that helps jog their memory to tell you the rest of what was going on, right? Does that make sense? Okay. You get more useful information. You can also use things, because again, not everybody knows words that go with feelings. So you can use stuff like this little thing. Help them with, pictorial identifiers, right? And a lot of times you'll see this used with kids if you're doing therapy. But you can still use it with adults. I've used it with adults who didn't have IDD because they weren't good at naming their emotions, right? So you can use something like that. And like I mentioned earlier, there's this disparity between expressive and receptive language. So by using, certain question types and avoiding others and allowing a lot of extra time for responses, you'll get better information and a better rapport. So most people with IDD have better receptive language skills than they have expressive language skills. So always just assume they understand you. And you can check for understanding, right? If they can't tell you yes or no, I get it, you can ask them, like, can you tell me what I said, and see what they say back, right? Or you can ask them to give you an example or something. If a person who's nonverbal, a lot of times, still can understand everything that other people are saying to them. And you can kind of tell by like, are they following you? Or, you can tell by facial expressions sometimes. Or if you give a command, if they carry it out, that helps you kind of figure out how much they know of what you're asking them to do. If you don't understand the person, Because a lot of our people have differences in their ability to articulate speech. Tell them. You can ask them to show you instead. Ask them to repeat the response. If they've got a caregiver, like sometimes can you say it slower? Can you say it louder? Sometimes it's just that. If they have a caregiver there, ask the person's permission to include them. If they give you permission, they can also kind of serve as an interpreter. So like if I'm talking and you don't understand my speech and you ask my caregiver, well, what'd she say? And they said, well, Susan said blah, blah, blah. It's always good to go back to the person you're interviewing, me, Susan, and say, okay, your caregiver said you said blah, blah, blah. Is that right? To make sure that the caregiver interpreted it correctly too. Because usually they can do yes or no. Even nonverbal, they can nod yes or no a lot of times. Who, what, and where questions are a lot easier than when, how, and why questions. So try to stick to who, what, and where's. And again, you can use the pictures, you can use the yes and no's. You can, open-ended questions are good. But sometimes you got to start with yes and no's to get to the right neighborhood on the open-ended question. So you don't want to just stick to yes and no questions because then you don't get any depth of content, right? It's like you're interrogating them, and that's not what you want to be doing. And try not to do a lot of what if questions, at least until you know the person better and know if they can understand them, right? Because you're dealing with somebody who thinks more concretely. So if you can keep what you're doing on a more concrete level, it's going to make more sense to them. Avoiding jargon and slang and other technical language is just good anyway, because your clients haven't all gone to counseling school, so try to avoid it anyway. Use the concrete descriptions. In our population, if you're a person that, blah, 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 they think that you literally expect them to know what you're talking about. And so that causes a problem, right? It makes them feel not great usually. So go back and check understanding, like rephrase, like you can rephrase what you told them and see if they still get it, kind of thing as well. And if you're talking about, like if the person has particular words they use to mean certain things, if you can find out what those are, you use their words when you can, okay? Again, that's good practice anyway. You're wanting to match your level of questioning or your level of conversation with their level of conversation. Like try to match, like, a lot of things are written at a 6th grade reading level, like a lot of assessments are and stuff. Well, not everybody's 6th grade reading level is going to be the same, right? So you want to kind of tailor your words, your vocabulary to whatever level they're on. Double negatives. You know what double negatives are? Never and not, yeah, in the same sentence. That's hard for people with IDD, so try not to use them, okay? Because they're like, what? They don't realize that double negative means positive, right? So try to do that. Avoid abstract concepts when you can. Because feelings are an abstract concept, so you can't totally avoid abstract concepts. But you don't want to be like talking at a calculus level. To use a math analogy, you don't want to be talking at a calculus level when they're doing addition and subtraction, right? So keep it basic until you have a better idea of what their receptive language is. If it turns out they have a really good receptive language, then you can get more abstract usually. And again, this was in a previous slide, I'm sorry. Use the extra alternative language systems. If the person uses a communication book, use it with them, kind of thing. So like if they're talking to you in short sentences, you talk back to them in short sentences. Don't give them a long 3-paragraph answer, right? Because they may lose track there in the middle of it, so keep it short. Use single clause sentences, same thing, to keep it short. You want to convey information in portions that they can digest before you go on to the next thing. Okay? Like you would with anybody with a short attention span, just to be on the safe side. And again, once you get to know them better, if you know that they follow you and their language skills are developed well enough, then you can, make it grow. To give you an idea, and again, this is just to give you an idea. So not everybody who falls in mild IDD is going to be the same thing as Piaget's concrete operations, right? This is a generalization. But give you an idea. So most people who've got IDD diagnoses fall in the mild range. And second biggest category is your moderate, going down to severe and profound, right? So that's just to give you an idea of where things fall. You all had Piaget? All right, we'll do this really fast. So sensory motor is like pre-language, and they're mostly understanding the world by the sensory information they get from without them, right? So you can look at like history, like so the caregiver's telling you what they think is going on, right? But you can watch the person who has ID, how are they responding to what that caregiver's saying, right? How are they interacting with other people? How are they taking care of their appearance? And that one, it kind of depends. If they have a lot of physical things that make it hard for them to care for their own appearance, then some of what you're seeing might be more a reflection of how good a job their caregiver's doing. So keep that in mind. But like, what's their activity level? Like, are they able to sit still, or are they bouncing all over your office, kind of thing? Any kind of stereotypic, ritualistic, repetitive behaviors can kind of let you know. Sometimes you may see something as anxiety, especially if it's a stereotypic behavior. And the caregiver that's how they calm, right? So some people that's agitation, but really they might just be calming themselves because they did feel it, but that's their coping mechanism. So you gotta ask, but you can tell a lot from affect and stuff as well. Pre-operational stages. So in a child of typical intelligence, this is about like how you would see the world from between the ages of 2 and 6. It doesn't mean that their emotions are at the ages of 2 and 6. It just means that they might be expressing their emotions that way, right? Because it has to do with their language. The person typically is more likely to see things from their own perspective rather than the viewpoint of others. They may have trouble manipulating information, drawing logical conclusions from information they're given. A lot of times, a person with moderate ID will like focus on one aspect of an object or situation and ignore other stuff because there's like one thing that they're really concerned about. And sometimes they have trouble ranking the importance of things. like everything's important, it's like, this one's more important than that one, they might have trouble with that. So Likert scales don't work well if you try those. Because it's hard for them to decide which is more concern to me right now. Everything's a problem. The moderate to mild, on the high end of moderate to mild. They're pretty good at logic in a concrete sense, but may still have difficulty understanding abstract or hypothetical concepts. But the people on the upper end of mild usually can, okay? They're not able to use deductive logic. Sometimes they have trouble taking like a specific concept and using it to predict the outcome of something else. They might have trouble describing symptoms, providing subjective data regarding their emotions. So like they might tell you they're scared when they're really mad, because in their brains, scared means mad kind of thing. But they're less egocentric with people with more severe intellectual disabilities. And they're the easiest group to adapt therapy for. So I'm going to skip down. Some of this is a reminder, but I want to skip down to the bottom bullet point. If a person uses communication devices, be respectful of all communication devices or assistive devices. So like a person in a wheelchair, it's like an extension of the person. So you don't just go grab a wheelchair and start rolling somebody around, right? You don't just grab their communication book. Here, show me on this. Don't do that. It's considered an extension of them. So, be respectful of that. So, again, you want to use a lot of paraphrasing, a lot of recaps, a lot of summarizing, a lot of clarifying. Plan for your therapy sessions to be long. All right, you want to allow more time for responses, but you're probably going to actually have a shorter session time. And you're probably going to have more of them. But the big thing is to, develop a rapport and an alliance with the person you're trying to help. So some things to keep in mind. What presenting symptoms led to the referral? How are they functioning now versus how they used to function? Which again, you may have trouble finding out, but try. How the mental health symptoms interact with behavior that's typical for the person's, what kind of stressors are they having? And what skills have they used to manage similar stressors in the past? Because just like somebody without ID, they've probably coped with adversity before, and they've got some coping skills in there somewhere. So when you find out what they are, you can expand on them and help them build them. And you also want to be aware of your own biases. And that's for anybody you treat, not just people with IDD. So let's talk about some modifications. So if you're using motivational interviewing techniques to try to get information, because it's not a therapy, schema, but it is something that's used a lot in therapy. You can use open-ended questions. You want to use a lot of the affirmations to help restructure the person's view of themselves and their ability to make changes. You want to use a lot of reflective listening. So these are all things you do anyway in motivational interviewing, right? And then the summaries. You're not really having to make a whole lot of adaptations for motivational interview. You're just slowing it down and using vocabulary that makes sense to the person, okay? You may use some more visual prompts, pictures, therapeutic games and stuff than you might ordinarily if you were using motivational interviewing with somebody. But in general, you're not making a whole lot of changes. For cognitive behavioral therapy, more sessions, you're progressing at a slower rate, using a lot more repetition. Okay. And you may have to include the caregivers more than you ordinarily would, especially if you're a therapist who's giving homework, right? Because you're asking a person who can't write to write stuff down or keep a journal, that's going to be difficult, right? So you're going to have to adapt your homework to the person's level of reading, writing, and whatnot. So as long as just know that you're going to be on the same concept for longer than you might ordinarily want to be. I am not, because we all got started today, I'm not going to do this next vignette. But I have it printed out. It was on a young lady who they were using modified CBT to help her with an eating issue. Okay. And so if y'all are interested, I have it, y'all can read it, but I'm not going to go through it in the interest of time because I don't want to run into y'all's other time. If you're into dialectical behavioral therapy, okay, you got to shorten the group sessions, increase the frequency, simplify the concepts. On the slide, I've got shorten the group sessions from 2.5 hours to 1.5 hours. You might have to go as short as 30 minutes, okay, depending on your person and the people in your group. And you might have to go from like once a week to twice a week kind of thing. You're wanting to increase the number of sessions that are spent on the 4 skill modules. So like you're spending more time teaching the skills than you might with somebody who didn't have an intellectual disability. So you have to simplify the concepts so that they can understand them. So break them down more, maybe change the language that you use to describe them and things like that. You're going to notice there's a pattern here, right? Everything has been shortened and simplified and use adaptive tools. That's kind of what happens in all these. Supported psychotherapy includes a lot of techniques that are helpful when working with people with IDD because it's a pretty directive way of providing therapy. So it uses techniques of suggestion, persuasion, and reassurance already, and so that makes it a good fit for people with IDD. And supportive therapy also borrows from a lot of other different therapies in terms of techniques. So, you can pick and choose what works for your consumer a little better. By adding in, therapeutic games, drawings, role plays. And you'll notice a lot of these things are stuff you might do if your client was younger, right? You were working with a kid or a teen. Same kind of an idea. You're into group therapy. The interactive behavioral therapy model, the research is suggesting is most effective with people with intellectual disabilities. And probably because it was designed for use with people who have some kind of cognitive disability, whether IDD or something else. So let's see. Studies have shown that it helps. Use of IBT was effective with people who posed an increase of suicide risk. And what it does, it's more into using action-based techniques that are drawn from the field from psychodrama. So you're not just having a conversation, it's not just verbal talking back and forth or written, like with a worksheet or something. They're actually moving their bodies and like acting out some things, and that helps facilitate learning and retention. Okay. Because you're engaging them in more than one level. And that would work with pretty much anybody, but they've got movement, they've got emotions involved, they've got verbal and the cognitive component, and it's all happening at the same time, and so it just makes it easier for them to retain. Some of the techniques they use in IBT that they borrowed from psychodrama, use doubling. So they're using role play. So, you know, the person's getting to play pretend, you know, kind of thing. And then role reversal and soliloquizing, and then trying to see themselves in the future. So if you look at it, you're addressing like abstract things, right? Like inner voices and whatnot, but you're doing it in a concrete modality, which is probably how it works better. Any questions so far? Okay. Common topics you're going to come across with the IDD population: grief and loss. And it's not just loss of family members, it's loss of staff, right? Loss of friends, particularly if somebody's in the system already, and so they like get moved from group home to group home, or they switch provider agencies, so all their friends were at their old group home and now they're in a whole different company, and so they don't see them anymore, right? Or a staff member they get really close to quits because, quite frankly, it's a very hard job with very low pay. Okay, so, you know, they have a lot of loss in their lives, right? They might have lost relationship with their parents because back in the day, doctors would tell parents, the best thing for you know, your kid has an intellectual disability, the best thing you could do for them is stick them in this institution and don't have contact with them. And you may think that was long enough ago that that didn't happen anymore. No. There's people still alive when that was the common practice, and they've spent a big chunk of their lives in institutions and they get let out into the community. And so they've had a lot of loss. They don't have a lot of support in the community anymore, right? And then trauma. They have medical trauma, they have social trauma, they have all sorts of trauma. Some of which could have actually contributed to them having IDDs in the first place. I know somebody else is talking to you about trauma, so I'm not going to get too much into it. But they have a lot of losses, right? And then a lot of times they're, like if their parent was their primary caregiver, and then their parent, you know, succumbs to old age, right? And so they've never lived anywhere, you know, nobody ever took care of them but mom, right? And now mom's too old to care for them anymore, even if mom's not dead. You know, they get uprooted from where they were used to being and put in different settings, and it's hard, right? So there's a lot of grief and loss. The other thing with grief and loss is sometimes in order that there not be a scene at a funeral, right? People with IDD aren't even told that their parent died. They're not included in the funeral. Stuff like that still happens. You think it wouldn't, but it still does. I know of, I don't know how old this person is. The person may be in their early 20s by now. When I met them, they were still a teenager. And I still don't think their parents told them that their dad died. The parents are divorced, so the dad wasn't living in the house. But the mom was telling me, oh yeah, I sent her a birthday card from her dad so she wouldn't know he was dead. Your expression is priceless, Kelsey. Yeah, it's yeah, you wouldn't think that people would still be doing that, but this was maybe last year I got told this, right? So maybe earlier this year. So, I mean, this still goes on, right? So they don't have a chance to grieve, you know, and mourn the loss. And then when they're looking for the person, why doesn't so-and-so visit me anymore? You know, that causes a lot of emotional distress. They think that they've done something that made the person mad at them. That's why they're not visiting. Or they're mad at the person for not visiting, you know? So it causes a lot of problems. Let's see. And then you've got, you know, attachment theory in general, right? So sometimes, you know, people have trouble bonding, you know, with their care. Like the infant's not behaving this way on purpose so that their parent won't bond with them, right? But if they've got like oversensitivity to stimuli, right? So maybe being cuddled is physically painful for them if they're oversensitive to touch, right? Maybe they're on the autism spectrum and they don't do eye contact a lot, and so the parent feels like the baby's rejecting them, kind of thing. You know? A lot of stuff happens to mess up attachment. So that also has an effect that might cause them to have emotional problems down the line. Or if they've had a lot of people leave in their lives, they start not wanting to attach to others because they're just going to get hurt again, right? So they put up a wall. And you've probably met people, or if you haven't yet, you're going to meet people like that without IDD who do the same thing, right? So there's a lot of insecure attachment in IDD. And sometimes you have the benefit of knowing what happened when they were young, and sometimes you don't. So you have to kind of to guess, or you just kind of, in trauma-informed care, it's like universal precautions. You just assume they had the trauma. So, you know, sometimes you just kind of have to make the assumption and operate from that viewpoint. And then a person's level of comprehension about like what death and dying are is going to have to do with their developmental age sometimes instead of their chronological age. So a person with profound ID might see more like somebody's death. They might see that, you know, they abandoned me, right? So they'll grieve, but they may not get that their parent's dead and that they're never coming back to see him, kind of thing, right? In severe to moderate ID, they're more likely to see death is temporary and reversible. What do you see on TV? Well, the person died, but they come back in the next episode, right? It's that kind of thing, right? So, or sometimes they might think that they caused the death. Like, I was mad at mom for doing whatever, and I told her I wish she was dead. And look, now she's dead, so I made it happen, right? So you have to kind of take these things into account when you're working with somebody. It's like, where are they in terms of their concept of death, how it happens, is it permanent or not, kind of thing, right? And then, you know, the less impacted by intellectual disability, you know, they might understand that death is death and there's no coming back to life miraculously there. But it's, they may not get that it happens to everybody at some point. Or they might, again, have some feelings of responsibility. They might have a lot of feelings of anger. They might start feeling afraid that everybody else they care for is going to die because this one person died, so everybody's going to die. So you, as a counselor, you can provide education regarding death and dying, and it's important to allow them the opportunity to have that closure, you know, through funeral services and stuff like that. there's a psychologist called Karen Harvey, and she's out of Maryland. But she has like little worksheets on her website. They're for free. And one of them's called The Goodbye Book. And so when she's working on death and grief and loss with her people, she sits there and they do the workbook together and stuff like that. But needless to say, COVID was really hard on people because especially when they were living in congregate settings and they were watching their friends and their caregivers, pass away, right? And so they had a lot of grief and loss to process. Plus the fear that it could happen to them. Okay, again, we're going to skip over this vignette. It's it's an example of doing it right. So James I want to say it was a parent who had been diagnosed with a terminal illness. And so when they found that out, they started working with him then about, what that meant and, promoted contact. And they talked about, well, would it be like after their parent was gone and, included him in the funeral arrangements because their loved one was making the arrangements ahead of time. And so they included James, what would you like to see? How can this help you? And they included him through the whole process, which allowed him to grieve more normally, right? It wasn't unresolved grief. So some of the most common types of trauma you'll see in this population: physical and sexual abuse, because predators look for easy targets, basically. And so if you want to abuse somebody, who better than a person who, if they report it, might not be believed. They might be accused of making it up. They might not be verbal, so they can't make a report in the usual way, right? So that in part is why a lot of that happens. There's also on the physical abuse, and people get frustrated with them and overreact, right? Or overcorrect or over-discipline. So again, I'm not going to go too deep into trauma and psychotherapy as it relates to trauma because I understand that's another lecture y'all have either already had or are going to have. So I'm not going to go there. But I do want to state that symptoms of PTSD in the IDD population often go unrecognized because the presentation differs a bit from that of the general population. The reaction to trauma is going to vary depending on the person's ability to communicate their emotional pain, right? So without an outlet of expression of distress or the ability to tell you what happened, a lot of times their expressions of emotional distress are communicated behaviorally, and they just get chalked up to being a behavior problem. So if they're aggressive or self-injurious or isolating themselves, people just think it's, they have a behavior problem and they have IDD. They don't look into the fact that somebody might be hurting them unless they see a visible injury. And so just know that. But for anybody with trauma, you want to ensure the person's feeling safe. You want to help them obtain a sense of control. You want to avoid unnecessarily exposing them to triggers. And you want to provide guidance and support to caregivers to help them reduce the patient's exposure to triggers. So this could be, you want to have this conversation directly with your client. So ask them, you feel better talking to a woman or a man, right? do you want a caregiver in the room with you, or do you not want the caregiver in the room? Because you don't know, the caregiver might be the one abusing them. I don't know. But you want to give them as much control over the therapy process as you can, right? Like, even if it's something like morning versus afternoon appointment, you want to give them a sense of control. So your best practices for adapting things, increase length of treatment. And if you're doing this like through an insurance company or whatever, you may be on the phone with that managed care organization, you know, negotiating and explaining why you need more than 16 sessions of CBT, right? You're going to adjust the complexity of your interventions to match the person's developmental framework. You're going to reduce the level of vocabulary, your sentence structure, and length of utterance to match their level of understanding. You're going to have to be a little more directive of the counselor than you might ordinarily be. If you lean toward directive counseling modalities anyway, this is not going to be a problem for you, okay? But if you're more in the, you know, well, what do you think should be done? You know, you're going to have to change that a little bit. Provide the patient with more visual cues, augment interventions with activities, right? And always remember to get the person's consent before you involve their caregivers. You always want to show your clients respect, using person first language whenever possible, right? You want to avoid saying things like suffers from, like Susan suffers from depression, right? Or Susan is afflicted with whatever, because those are stigmatizing words. Unless you're, all right, I do have a caveat in here. If you're pointing out the suffering or affection. So if it's like, are you suffering from an earache, right? Or something, yeah, something specific. You mentioned the person's disability when the disability is relevant to the issue being discussed, but if it's not relative to the point, you don't need to dwell on it, right? You also need to consider who your client really is. So, you know, like when somebody's court ordered to you, your client is the judge. In a way. Did y'all know that? Okay. It's not the client you're doing therapy with, but yeah, that's actually who hired you. So people with IDD are often referred by others for counseling services. So you might be placed in a situation where the demands of the entity who hired you seem to conflict with what they perceive the person with IDD's needs, right? So you're going to need to be aware that you may run into that situation. You also have to determine if the person who's your identified patient there is actually wanting to be there and if they're receiving any benefit from the service. They might get sent to you because you know, something that happened. It's like, you have to have counseling. And they're there because they go because somebody, you know, put them in the van, took them over there, dropped them off at your office, but they really don't want counseling, right? Maybe they're not ready for it or whatever. So you may have to parse that one out. Age-appropriate activities or age-appropriate services, that's referring to the principle of treating people like you would others of their chronological age, okay? A lot of times people with IDD and adults with IDD are wrongly treated as though they're children because of their developmental delays. So everybody's talking to them like they're a little kid. Don't do that. Dignity of risk refers to allowing people the opportunity to take reasonable risk in order to achieve richer, fuller lives. So the service provision system and the families of people with IDD are sometimes so focused on maintaining the person's safety, you know, either because they've wrapped them up in cotton wool. They don't want them to get hurt, right? that the person with IDD is not always afforded the opportunity to take reasonable risks. To learn by, okay, so let me see an example of reasonable risk. The person lives a block away from the store. They have money. They have street safety skills. They know to look for traffic. They know their way to and from the store, right? Dignity of risk would allow them to walk to the store, buy what they want, come back on their own. The caregiver is afraid that the person, yeah, and let's add in, they don't tend to run away. They don't get in arguments with people. They don't get in fights on a regular basis. Okay, there's no reason not to let them walk to the store. But the caregiver might be, oh no, we can't let them go anywhere by themselves because what if something happens, I'll get blamed, right? You have to wait to go to the store until we can all go together in the van. You know, so that's not allowing the person dignity of risk, kind of thing. It's a non-counseling example, right? But, you know, in counseling, you know, are the people you're providing counseling to, are they always going to make decisions you want them to make? No, they're not going to. You might want them to, but in the real world, they don't, trust me. So, you know, you got to allow people the opportunity to make their own decisions and to live with the consequences of those decisions, right? So that's what dignity of risk is about. So here's some references, lots of references. Okay. Got a couple of things going on. I want to show you some stuff that might be useful. And in addition to that sign-in sheet that was floating around somewhere that I hope everybody signed, I need y'all to do an eval for me. So you can do the eval either by scanning the QR code, or I have paper copies if you just want to do it real quick. You don't need to fill out the last question on it because it's asking you for CE. Like if you want a CE, give me your email address. I'm not giving you CEs. Okay. So you can leave that blank. If you want me to send you a certificate of participation after I get in the office on Monday, you can put your email address and your name, and you'll get a certificate of participation. But your teachers know you're here, so that's what's important. So, useful things. And I went by the office this morning and stole them, and y'all can look through them, and I'm sorry about you guys on Zoom. I didn't know this was a hybrid presentation. This is the DMID-2. It's put out by the National Association of the Newly Diagnosed, and it took the DSM and kind of adapted the diagnostic criteria for people with intellectual disabilities. Very useful, okay? So to give you an example, and it's set up like the DSM, right? It's got its chapters and they're kind of the same thing. But it starts out, well, it starts out with an introduction on that. But it has a chapter on like behavioral phenotypes of neurodevelopmental disorders, which is handy. So I'm going to tell you part of one that just, because I learned the hard way because I had somebody with it on my caseload. And I didn't know about this book back then. So Prader-Willi syndrome, okay? For some reason, people who have that particular genetic disorder, a lot of times they also engage in skin picking, tantrum behavior, and for whatever reason, they take their clothes off during the tantrum, okay? It just seems to go across that. Prader-Willi is a genetic disorder that basically, I guess they don't have that part of their brain that tells them when they're satiated, when they're full of food and don't need anymore, it doesn't work right. So they will go and they will eat everything in sight to the point of causing themselves serious health problems. Okay. So there's a lot of food-related behavioral issues that go on with that particular genetic disorder. But they have, you know, like, you can look up the genetic disorder and they'll give you like a list of things that you might see in a, like across that population. It doesn't mean that a specific person with that genetic disorder is going to show all those typical behaviors for that genetic issue. But it kind of gives you an idea. It's like, all right, so is this a sign of mental illness? Is this a sign of behavioral, you know, conduct problem kind of thing? Or could it be related to their genes? You know, and so it like helps you parse things out a little bit. But it will take, let's find one. I don't want to do autism. So it talks about like frequency of ADHD in people with IDD. So we'll pick on ADHD. So like here's the DSM diagnosis in this column. And in this other column, you have like how you might want to apply that criteria to somebody with an intellectual disability. And they will also tell you, it's like, if a person has mild intellectual disability, you might want to look at these things. If it's moderate, you might want to look at these things and so forth. So it's handy. What translates IDD or DSM into IDD land. This one is psychotherapy for individuals with intellectual disabilities. It's also put out by the NADD press. And it went through and they did research and they basically said, okay, we looked at this kind of therapy and these are the adaptations that research says works for people with IDD. So it's very handy. If anybody's interning at Turning Point, y'all may have borrowed this book because they borrow it from me a lot, okay, if they get one of our clients in there. So it's really handy, it's an easy read, and there are others like it out there. But this is the one we happen to have in the library this morning when I went over there. This one is like how you diagnose with intellectual disability, okay? And it talks about system supports, test scores, you know, what valid measures will they accept to come up with a diagnosis of intellectual disability. It's put out by the American Association of Intellectual and Developmental Disabilities. So just some handy things to have in your toolkit if you decide you want to work with this population. Because just like in your case study, it's about cultural competence. You educate yourself about IDD culture, which is really hard. I mean, there's no one because IDD encompasses so many things. It's not just the guys with intellectual disabilities. The state of Texas and other states have this big long list of things they call related conditions that if they manifest in a person, generally before the age of 21, but there's a few that can be up to 22, or I'm sorry, generally before the age of 18, but some of them go up to 21 or 22 and they'll still count it. That qualifies people for IDD services. So on your caseload, you might have somebody with an IQ of 50 and a low adaptive behavior score, which is what you typically think, intellectual disability, right? You may also have on your caseload a lawyer with cerebral palsy who qualifies for IDD services because the nature of their cerebral palsy necessitates that they require support similar to that of a person with intellectual disability in order to live and survive, right? Because their physical health is so bad that they need all the same kind of support. So the state lumps them into IDD services because cerebral palsy falls under developmental disability. People with severe epilepsy might be in there. People with a head injury sustained before, I want to say that's the one I know it goes up to 21, it might go up to 22, get qualified. So they may have had, everything going on. They may have even been in college. But if their head injury changes their functioning to the point where they qualify for services, or where they show that they need support similar to that of a person with an intellectual disability, they'll be thrown into IDD service pod, right? So it's a huge category of different conditions and people and whatnot. So educate yourself about whatever part of that giant realm applies to the people you're trying to work with, because it's just part of being culturally competent. Do y'all have any questions for me? Nothing? You'll say it away. Oh, Dr. Idas. Okay.
So I've done psychological evaluation or psychosocial evaluation, and I cannot diagnose a client with IDD on my own, even if I'm trained to administer an intelligence test, or even like with autism. I can't diagnose a client with autism. It seems that I have to have a psychologist or a psychiatrist review the evaluation in order for them to be given that diagnosis. Could you maybe put
What's your doctor do?
Dr. Valoran, for example?
No, but I mean, all right, you could. I mean, if you're, all right, so you're giving an objective measure, you can give a person the label. Now, the state won't accept it. Right? So, all right, you want me to go into getting into services? Because that's a whole other,
Just maybe
I mean, there's time, but, okay. Okay. Disability, okay. So Texas has its, and I don't know how other states do it, so this is how Texas has it set up. A person has to have something they call a determination of intellectual disability examination. This can be done, that's what I said, you could be done, you just have to get certified as, blessed to do DIDs. So, because it's not projective testing, you're allowed to, you're allowed to do this. They're objective tests. But, so back when I did them, that's why I said it's been a long time since I did testing. But back when I did them, I had what they called a determination of mental retardation certificate. But now it's determination of intellectual disability because we don't use the term mental retardation. So sorry about that, because I just broke the law twice. But you have to show that you are qualified to, give the assessments. But the local authority for your part of the state has to either do it themselves. So we have somebody who's a licensed psychological associate doing them because she's been blessed by the state to do them. Or it has to be somebody else who the local authority has contracted with to do them, or to certify somebody else's testing. So like our LPA, say you did testing and the family brings it with their child over to the local authority and says, I want my kid in services. Here I got, this test. So our LPA can elect to either, review everything they bring and certify the existing testing that was done, which a lot of times they'll do with an outside psychologist or whatever. Or they'll do a whole new, round of testing. A lot of that depends on which tests were used, how long ago it was, stuff like that. But yeah, they actually have to contract with somebody, and then I'm trying to remember, because I worked in an institution when I had mine, so it kind of came with the job, when you got hired, they did they vetted you and, went off to the state, and you came back and you had a little piece of paper saying you were certified. So I suspect that we have to send our contractors' qualifications off to the state, and he comes back certified to do it as well, like our in-house person. So yeah, you can get diagnosed at the school district, but that doesn't mean the local authority is going to accept it necessarily. They usually do, but I mean, but there's no guarantee, you know, it's like, oh, they used the wrong test, or it says here that the person was psychotic at the time of the, you know, whatever. Because, I mean, when I did testing, like they'd come in and their mental illness wasn't fully under control yet in the institution. And when they got better on that end, you could go back and retest them and say, you don't have IDD anymore, bye, you can go home now, you know, kind of thing. So some of it, you know, has to do with testing conditions as well. If, you know, but it just depends. But so, because LPCs are allowed, you know, to do it, you just have to demonstrate that you've had the proper training and certification and the instruments used to make the diagnosis and determination. My master's is in psychology, so it wasn't an issue, you know, but any other questions? Oh, I should tell you about interest lists. Since I just spent the week listening to people gripe about interest lists. So when you go, all right, so when you go to MHID for mental health services, right? You're gonna get screened for services. They're gonna decide if you have a mental illness and if it's severe enough to qualify for treatment there, or if you should go somewhere else, and they'll, you know, link you to it. But you get open to services after you get screened and diagnosed. And then they start hooking you up with treatment, and, you know, you go about your merry life, right? On the intellectual disability side, and that first screening and admission to services, that's called an intake on mental health side. On the IDD side, intake kind of means that you've expressed an interest in services. You may or may not have brought some medical records with you, or they're requesting medical records. But it doesn't mean that you're open to services after you finish the intake process. So it can take a while to get into IDD services because they have what they euphemistically call interest lists for services. So this includes any service. So this includes basic services that aren't waiver programs. It also, but mainly that one is because of, like, how many people do they have to provide service coordination, and that they can't admit you till you've had that determination of intellectual disability, you know, panel. And so you're like waiting to have that happen, right? So that's mainly the reason for the general revenue wait. But they have these things called waiver programs. And waiver programs are what usually pay for group homes and personal attendant care and day programs where you learn skills and all sorts of things, right? They're Medicaid waivers. The wait list for those, to get into those, is about 15 years long. So if your work, and it's not the local authority's fault, that one's from the state. The wait list for general revenue, that's the local authority's fault. But the waiver service stuff, like the programs I was mentioning, we serve the HCS, Texas Home Living class, all that. So if you're working with a family and their loved one or your client has intellectual or developmental disability, or you think they do, and the family doesn't know about interest list or whatever, go ahead and tell them about the local authority, because the local authority is who gets people on the list, right? Encourage them to get their name on the list, even if they don't have any needs for extra support or whatever right now, because in 15 years, they probably are gonna need it, right? Or when they hit adulthood, if they're a kid. This gives them an avenue to where they can at least, you know, live on their own, or even if that living on your own is a group home or a host home or whatever, for when their parents can't take care of them. Okay, So that's the dark part of IDD. You can't get into services because the need is greater than the capacity that the state has allowed for. Any other questions? I always forget to talk about that because I don't like to think about it. But that's important to know as a counselor, because if you're trying to hook somebody up with resources, you want to know how long it takes to get to the resource. Right? That's not to say that there's not like ways to jump the line. There's emergencies and stuff like that, but you don't want to rely on those. So anything else? Okay. Were y'all able to all hit the survey from the QR code?
You wouldn't mind like stepping to the side so I can.
Oh, am I in the way? I'm so sorry. Okay, because like I said, I've got paper ones here. If you, y'all should have told me I was blocking the QR code. Now, if you want to put any of this into practice, I've got case studies I can share with you. But that's up to you, because you've got, I finished a little early from your time frames. Let's see how well they paid attention. Or if y'all want to, thumb through the books, you can do that as well. There are a couple of therapy modalities I don't mention in this, but work really well with people with IDD, especially if it's an anxiety or trauma-driven thing. One of them's EMDR, because it's not relying so much on the verbal. So it works really well with people who have IDD. If you can find an EMDR therapist, one who take their Medicaid and who, will make some minor modifications to it. And there's another one that, I don't know anybody who uses it, but the research is really compelling. It's relaxation response training. And the thinking behind that, there's a certain position that, like physical position, you ask people to assume, and you can like just grade it on a point system whether or not they've got their body in the right configuration. And the research suggests that if you're able to, get in that pose and, maintain it or whatever, it helps you self-regulate. And again, it doesn't rely on verbal at all. You don't have to be able to talk, they don't have to be able to talk to you and tell you how they're feeling. So that one is the research suggests is really good with people with IDD as well, especially those who can't talk with their words, kind of thing. So I don't have those two in this one. I have them in the other one that I didn't show you today. I keep forgetting I'm a BMDR on this one. Give you your mic so you can talk a little bit.
I'll take a 10-minute break, and then when we come back, we'll do video. Can I look at your books real quick? Yeah. They're really great.
There we go. I can turn it up a little bit. Okay. So, question, what did you notice in the video? What were some challenges that Libby was having?
Thing. Wasn't, she was kind of making mistakes, like, I think they.
I agree. I agree. Anybody else think anything different? Yes, Phoebe? Yeah, she didn't mention anything about the bus, which I was like, where did that come from? So if you guys were in Gustavo's place, how would you try to work with Libby differently? We are not gonna do it Gustavo's way, 'cause Gustavo's way is not the right way. What would you, how would you do it differently than Gustavo? Yeah. I also noticed that he kind of treated her like she should know better, if that makes sense. Like he treated her like everybody else, but we could see that she needs extra help. But it just seemed like Gustavo was kind of frustrated, kind of like what Miss Susan was saying, like people get irritated and want to hurry up and do it. And that's kind of the vibe I got from Gustavo. Yeah. Anybody else? Yeah, Phoebe? Yeah, no, I think that definitely would have been helpful because it seemed like she shut down real fast and she was uncomfortable with him within that first conversation. Okay, any other questions?
They like just asking her to like, what would make
And did he ask her anything about what was the previous lady that she was working with? Angel? Like, did he even ask her, like, how did you and Angel work things out? He did? No?
she just pretty much said that whenever he asked, like, what would you felt like?
I think kind of like what Phoebe was saying, like, or was it you, Crystal, doing like a day-to-day walkthrough with her to kind of understand what Angel asked of her, to help her transition into change. Because he even identified, like, I know you don't like change, but trying to make it more easier of a transition for her. Okay. Any other questions? No? Okay. Well, that's all our training for today. If you have any questions, please email us, and we will get back to you Monday. We're going to let you have your Saturday and Sunday. All right. Well, that concludes our training for today. Everybody on Zoom, you can log off. Thank you. Lena, she left.